Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
Hi, I'm Carlos Zarate. I'm delighted to be participating in today's session on treatment-resistant depression. My topic for today is glutamatergic approach in treatment-resistant depression, or TRD. Here is my disclosure. I'm a full-time employee of the U.S. government. There is a considerable need for improved treatments for treatment-resistant depression and suicide. There are adverse effects of depression, including the disruption to personal, family, and social life, occupational impairment, and risk of suicidal behavior. There are limitations with our current treatments, including low remission rates, 30 to 40% have treatment-resistant depression, and there's a considerable lag of onset of antidepressant and anti-suicidal ideation effects. Towards the bottom, this figure depicts a major depressive episode from euthymia all the way to a major depressive episode. If we don't intervene, it takes about 6 to 9 months for an improvement in major depression. With our treatments, we initiate a standard monoaminergic-based antidepressant, which have a considerable lag of onset of 10 to 14 weeks. So we shift the time curve response towards the left. With next generation rapid antidepressant and anti-suicidal ideation treatments, we'll have an onset within hours or a few days at most. In order to develop next generation treatments, we should have a better understanding of the new and cellular molecular targets. Now, we tend to see mood disorders as impairments of resiliency and plasticity at synaptic and circuit level, what we refer to as synaptic and circuit homeostasis. There are different theories of how ketamine and other rapid-acting antidepressants might work. One is that ketamine has a direct effect on NMDA receptors that affects eukaryotic elongation factor 2 in a series of intracellular signaling cascade changes that lead to protein synthesis. Another contemporary theory of ketamine's mechanism of action is that it blocks NMDA receptors on GABAergic interneurons. When it does so, it decreases GABA inhibition, resulting in pyramidal excitation, which then, as a consequence, leads to an evoked release of glutamate. Glutamate then activates AMPA receptors, produces a change in BDNF, activates the TRKB receptor, a series of intracellular signaling cascade changes. And towards the top right, we can see that the circuits and synapses are restored. That is one of the theories of how ketamine might work. Now, a limitation of this theory is that when you block NMDA receptors, that might be associated with psychomimetic or dissociative side effects, and even the risk of abuse potential. So could you produce an evoked release of glutamate without blocking NMDA receptors? There are alternative targets in candidate drugs. One is mGluR2 antagonist. You block the receptor, produce this evoked release of glutamate, and you would be removed from NMDA receptor inhibition. The other possibility is at the GABA-A receptors. You would also use negative allosteric modulators, produce this evoked release of glutamate. And then at the level of the metabolite of ketamine, 2R, 6R, H, and K, you could also produce this evoked release. In an earlier study in the mid-2000, in this study, what you see is that ketamine reduces immobility in the forced swim test in rodents, and this signifies antidepressant effects. If you pre-treat with a blocker of the NMDA receptor, in this case MBQX, you block the antidepressant effects of ketamine, implying that AMPA receptor activation is important to its antidepressant effects. Now, all of these drugs, candidate drugs I mentioned, have this property that their antidepressant effects are also blocked by the AMPA receptor antagonist. Furthermore, these different candidate drugs I mentioned produce an increase in gamma power. Gamma power is a measure of in the 30 to 50 hertz range that has to do with excitation, inhibition balance, and a surrogate of neuronal synchronization. Now, this slide summarizes the preclinical effects of ketamine. Here is the channel, the ionotropic receptor, and within the channel at the PCP site in orange are the antagonists at the PCP site, ketamine, S-ketamine, memantine, AZD6765. One can avoid the channel in order to minimize side effects either at NR1 with these compounds or at NR2 with these other compounds, hoping to preserve the therapeutic effects but without the side effects of ketamine. In orange, we see that there's very strong preclinical evidence in the other domains as well. And most of these other drugs had matched the preclinical effects of ketamine, meaning that at least in theory it should work in the clinic. Now, this is a brief summary of the studies that have been done over the last decade or so. At memantine, a non-selective NMD antagonist, we did not find antidepressant effects compared to placebo. Another study by Smith and colleagues also did not find therapeutic effects for ketamine, for memantine. Here, AZD6765, lenisamine, we found very brief, with one infusion, very brief, short-lived antidepressant effects lasting minutes. Another study by Jerry Sanakura also found preliminary evidence of antidepressant efficacy. However, when this compound moved into a larger study, almost 300 patients, we see that there is no significant separation from placebo. When you inject it in humans or mice, you obtain 24 metabolites within minutes. And so how do you separate what is relevant versus not? Because some of them might be involved in side effects, other into the therapeutic properties. So you do so by chemical process. You denature ketamine and creating a stronger bond that prevents metabolism. When you do so, you don't have any antidepressant effects, but still have the side effects. In our candidate drug was tested in preclinical studies, and we show it's not an NMDA receptor antagonist and does not have dissociative side effects, and it's AMPA activator. And so it says we separate the wheat from the chaff. So in our ongoing work, we're going to continue drug development and investigate novel targets. Thank you for your attention.
Dear colleagues, I'm intensely happy that you are interested in this presentation on treatment-resistant depression, and now even a little deeper, deep brain stimulation for depression and obsessive compulsive disorder. My name is Thomas E. Schlepfer. I head the Department of Interventional Biological Psychiatry at the University of Freiburg. It's a very small department looking only at effects of deep brain stimulation in psychiatric disorders. A very interesting field where lots of things are going on, and I'm happy to inform you about our operation. And I'm really happy that the CINP Congress is held at these really tackling times. There's a whole group of people who help me. They're all mentioned on this slide. Now, first of all, what does it refer to? What do I mean with deep brain stimulation? What you see here is not a cartoon, it's an actually planning slide. You see this green structure. This is the superolateral, the superomedial forebrain bundle in the brain. The key structure which we and all other animals, all vertebrates need to get attention, to get aroused. It starts deep down in the brain fans out to the nucleus accumbens, and then to the prefrontal cortex. That's why we use it as a really good path to get to activation. And we know from many studies that exactly this structure is dysfunctional in major depression, and as it turns out, in obsessive compulsive disorder, that is the disorder which is really related to major depression. The big white structure you see are the electrodes, both in the head. The straight line is in the head, the curved one outside. Don't worry, the actual electrodes are not so thick, they're much thinner. This is an MRI artifact. But the most important point of this picture is that the electrodes point exactly to the origin of this superolateral forebrain bundle. It's really at the origin where we can exert the most effect. Now, what did I tell you about SLMFB stimulation? Again, the SLMFB is the superolateral branch of the medial forebrain bundle, a very important stimulating brain pathway. In the first study, we showed the effects. In the second study, long-term, in the same study, the first long-time efficacy data. In 4C2, we showed the same effects in a larger patient population. Then there is some animal data which appeared unrelated from our group, where optogenetic VTA stimulation, VTA is part or very close to the SLMFB, has antidepressant, acute antidepressant effects in rats. Then 2016, independent replication at the Department of Psychiatry in Houston, Texas. Same stimulation parameters, same place of stimulation, same effects. And this year we showed, last year we showed, and this year we will publish very strong effects in OCD. That's really the new piece of data. Lastly, I want to thank all the people who helped in this study. I'm talking about it, but many people contributed. There are the functional neurosurgeons, which are very important, translational neuroscientists, which contribute to the data, and we do a lot of neuroethics work, which was not part of this presentation, but these are people which contributed in a very valuable way to this study too. Thank you very much for your attention. I wish you a stimulated, not necessarily electrically, but a stimulated day at the CINP. Have a great day.